Hello, and welcome to the CMHC podcast series entitled The Utility of CGM in People with Type 2 Diabetes. I'm Dr. Anne Peters from the University of Southern California, where I'm a diabetologist, and joining me today are my colleagues, Dr. Irl Hirsch and Dr. Grazia Aleppo, and they're going to introduce themselves. Irl?
Thank you, Anne. My name is Irl Hirsch. I'm a professor of medicine at the University of Washington in Seattle.
Grazia?
I'm Grazia Aleppo. I'm a professor of medicine at Northwestern University in Chicago.
Great, and they're also my dear friends, and I'm very excited to be doing this with them. So in this series, we will discuss important considerations and practice pearls about the role of CGM in the management of people with type 2 diabetes. In this first part, we'll talk about the rationale for CGM in people with type 2 diabetes. And just as an aside, I'm going to start out by saying that I think the other two on this call with me, are both big fans of CGM, in part because we've used it so much and we've used it to help patients. And whenever I talk about what it is that makes my patients' lives better and helps them get to their targets. And I think that the big rationale overall for using CGM for all of us is that I think it's enhanced patient care. But first, I'll turn to Irl and ask, why is it that you think it's important to use CGM in our patients with type 2 diabetes?
Thank you, Anne. There's really two different answers for that. Some of it proven by evidence and anecdotally, and the other part of it is maybe a more esoteric, but just as important part. We know anecdotally, in particular, that people with prediabetes, maybe early type 2 diabetes, that the CGM often will change behaviors in a big way. And it doesn't matter if it's somebody with type 2 diabetes on insulin. It doesn't matter if it's even somebody with type 1 diabetes who makes no insulin. Watching those blood sugars go up, watching those trend arrows, watching the blood sugars go down with physical activity, with medication, it's just human nature. The issue right now is that we don't have as much data as we would like to in people not receiving insulin. But that's going to change. And we do have data, but it's just not enough to make it standard of care. And I will let Grazia talk more about that. But I think that everybody has or needs the opportunity to use it, even occasionally, the patient who is maybe on metformin alone. It's even helpful for our patients with that in that situation, again, because of what it does with behavior. But there's another reason. And it's a reason that we've been looking at here with my group in Seattle that it's not always obvious to most clinicians or patients for that matter. And that's the fact that the hemoglobin A1C test, which is the test we use to increase the medications or decrease the medications often in type 2 diabetes, can often be misleading. Now, when we first started using A1C, really 40 years ago now, we knew about hemoglobinopathies and anemia. But what we've learned more recently is the fact that everybody's hemoglobin A1C is different because of differences in red blood cell survival, but also differences in something else, the way glucose binds to the hemoglobin, or for that matter, all of the proteins. But the more important pragmatic fact about this is that we have shown that 22% of the population, their A1C compared to the estimated A1C or the GMI on the CGM, 22% of them, it's 1 percentage points off. And in half the population, the A1C comparing the estimated A1C or GMI with the measured A1C is 0.5% off. So if the GMI or estimated A1C is 7, in 22% of the people, it's going to be above 8 or below 6. And so one really needs to know from a CGM if the A1C is concordant or discordant and how much that is. The good news is it doesn't change over the course of one's life for the most part. There are some changes that may occur, but I only bring this up because we have traditionally increased medications based on the A1C. And what I'm saying is without a CGM, at least doing it once, you don't really know what that A1C means.
Yes, I couldn't agree with you more. And what I do, because our electronic medical record doesn't track anything, is that with every appointment, I track in parentheses the GMI, and then I write down what the actual measured A1C is, so that I know when I don't have a measured A1C what the relationship of that individual's GMI is to the measured one. And so I can say, well, your GMI is this, and this is what your patterns look like, and that NU correlates with an A1C, because patients are still interested in their A1C, but I think many of us have gotten our patients interested in time and range and GMI as a concept. So Grazia, why don't you discuss some of the evidence for CGM in people with type 2 diabetes? I know you're an expert.
Well, I don't know if I'm an expert, but I've enjoyed working with you and Irl on many clinical trials together. And, we know very well the Diamond study showed without a doubt that people on multiple daily injection with type 2 had an increased A1C using CGM much more than people who were just using BGM, although also multiple daily injection over 24 weeks. But we also know from the mobile side that just Irl was mentioning before that, patients with type 2 diabetes, not a multiple daily injection on basal insulin alone, were able to have over 8 months a substantial decrease in hemoglobin A1C compared to the patients who were wearing on BGM. But the thing that was more striking was that after those 8 months, when they were re-randomized to either continue CGM or discontinue CGM, those who discontinued CGM had a decrease in time and range by 12%, which is almost 0.3, 0.4 A1C. And of course, the group was not sort of a power for the analysis, but the point is there that the CGM made the difference. And it was not only that, but also for patients who were seen in primary care. So our job was just to train the patient and monitor, but not really to make interventions. And at the end of the day, these participants had the same amount of insulin, same number of medication changes, same dose of insulin. So it wasn't the medication, it was the CGM. And I couldn't agree with Irl more when you look at these patients who get this first aha moment and they see what even a professional CGM can do to show them their targets and the numbers and the excursions of a bagel, Cheerios, whatever. But there's another study just came out from Dr. Aronson over in Canada with patients without insulin, only on oral medication, who went for education versus education plus CGM. And in those on CGM plus education, they saw a much better number of hours in time and range. It was like 4 hours a day or more. So that is a huge amount of information, even though we only have few patients compared to, of course, the population with type 2. But these data are very interesting because they are telling us that this is not just our, observation of us seeing patients on a regular basis, really is reproducible, even without insulin now.
Well, yes, I think those are really good points. And I know we'll talk about it more. I also think that, and this is hard to study, but my patients on CGM like that they feel empowered. And there's some patients who can't take too much information, but there are other patients where knowing makes them feel better, less lost about what's happening. And over the weekend, a friend's mother of mine has diabetes and was fretting always about finger sticks and it hurt and blah, blah, blah. She's 99 years old. And I went and I said, Joyce, would you like a continuous monitor? And she'd heard about it and she really wanted it. She's 99 and still a very good mind. And, she loves it. It's like made her whole life. And I'm not actually that concerned, but she is on a sulfonylurea agent and I don't want her to go low. And she just loves the knowledge. And it's interesting to watch somebody that I know this well adapt. It was a little hard to find actual places where she had enough subcutaneous tissue to put it. But, she's just there, this 99-year-old, and they're texting me and telling me her blood sugar. So I think there is something that's really important in terms of what patients like about CGM. And I think that that's something that's sometimes hard to get insurers to pay for. But I think that diabetes is such a pervasive issue, and to have some further sense of empowerment and control is a good thing. But Irl, I want you now to describe as best you can the types of CGM and make sure that people understand what we now have available and how they should be used.
I'm happy to do that, Anne. But one other point I want to make first is more of a teaser. And I'm hoping we have an opportunity to talk again after the ADA scientific sessions, which will be at the end of June, because we're looking at the discordance between the GMI and the A1C as sort of interesting, and knowing when we do an A1C if it matches the actual glucose levels or not. Well, the teaser is this is more than just something interesting. There's actually, we think, some biological importance to the discordance. And I will leave it at that until after the meetings because I'm embargoed. If that's a teaser or not.
That's good.
So when we started with CGM, and both of you, I think, remember, we were all probably close to diapers in 1999 when the first CGM came out from MiniMed, and that was prior to when Medtronic had purchased MiniMed. All we had was what we called professional CGM. And we still have that now, where the CGM is capturing the glycemic data, but the patient can't see it real time. And there still is a role for CGM. We use it a lot in our clinic with new patients who come in, and we don't know where to start. And maybe we have an A1C, maybe we don't. But again, we've become so distrustful of the A1C because of so much discordance, and we get so much more granularity of data from CGM. We will often put on a professional CGM as a place to start. In fact, that's the most common way now in 2023. We use this professional CGM. It's generally very well covered. Depending on which one you use, you get 10 to 14 days of data. Extremely helpful, especially in the type 2 patient when you're not sure where to start. With that being said, most of our patients are not using professional CGM, but they're using personal or real-time CGM. There are now 4 different companies FDA approved in the United States for this. In our clinic, all of the companies are represented. We know there will be both upgrades in the current real-time CGM with the 4 companies that are there, and I would not be surprised at all, given how much benefit the CGM provides, if there might be new companies in the future for CGM. I think the key part of the personal or real-time CGM is that the patients need to have engagement. The patient side, I think, for the most part, is relatively easy. There are exceptions for that. I think the more important thing is with the personal CGM is the physician engagement. Reviewing the data with whatever software is convenient for that physician. I hear over and over from patients, especially new patients, that they've been wearing their CGM for 5 years, but the doctor's never looked at it. And that is where I get all of my information from, because with the CGM, especially for people who take insulin, but not even necessarily, I can see how the patients are thinking. I can see their behaviors. And for me to understand the patient's thinking through it, that's a huge benefit for me trying to help that patient.
Those are really good points. And yes, it's whatever CGM will work for a patient, because we do have more than one type and they have different features. And I would encourage everybody to learn about the features of the various types of CGM. But as providers, we have to look at the data. And historically, providers didn't look at SMBG data. And now there's always a reason to not be able to look at CGM data, but it's really simple. And I think people need to learn how to do it. Now, I'm going to stop this podcast and encourage you to come back for podcast 2, where Dr. Aleppo is going to be discussing the current 2023 ADA standards of care in terms of how these devices should be used. So thank you, you two, and hopefully you'll listen to us on our next podcast.
Thank you, Anne.
Thanks, Anne.